let's go into the topic of trauma-informed care from a resilience-informed lens. I'd love to start us out with the principles of trauma-informed care, and you can find these online at the cdc.gov. The first of these is safety. Of course, we want our people to feel safe with us, and what facilitates basic safety in the therapeutic relationship is trustworthiness and transparency. I mentioned earlier in this module that safety is a tricky word sometimes because it can sometimes point out where we're not safe and currently not safe. And we live in a world where a lot of the people that are coming to us for support are currently in unsafe experiences, whether that's relationally, whether that's culturally, whether that's due to access to resources such as a house, such as financial resources. And so the relative safety within the therapeutic environment is the foundation of good care. And then on top of that, also being able to attend to those safety factors outside of our work. Sometimes we need to collaborate with other community services to work on housing support or access to food and so forth in order to also support that safety. As I mentioned, trustworthiness and transparency facilitates that safety in the room. And that another key element here is having access not just on that dependency between client and you as the only source of support, but also building in more peer support systems, whether that's attending support groups, whether that's finding who are the good support people in our clients' lives outside of therapy, who can they call when they're struggling, who's a safe person to talk about their difficulties with or to bring their emotional vulnerability to. Within therapy, we also look at the importance of collaboration and mutuality. We've already been speaking about this, haven't we? Collaboration is the ability to kind of co-pilot the process together to ensure that your client can tell you what's working and what's not working, and so that we feel like we're on an even playing field as we progress through treatment together. We want our clients to feel empowered and at choice at every stage of the treatment process. And then the final principle here is that we are acknowledging and respecting the cultural, historical, and gender issues that may be impacting our client's sense of self and sense of safety in the world. So the phasic model of trauma treatment has been and continues to be the most well-researched, evidence-based, supported approach to successful trauma recovery. And for many, many years, I want to say for about 30 years, starting with Judith Herman's first book in the early 1990s, I think it was 1992 that she first came out with her book, Trauma and Recovery, and introduced the phase-based model. It was always referred to as the triphasic model. 3 phases of treatment, the first of which is to establish stability and safety by developing resources. Then we go into phase 2, where we process traumatic material in a well-paced and regulated manner. And phase 3, where we reintegrate new experiences into our sense of identity and our relationships. But just this year, which is 2023 to locate when I'm teaching this material, Judith Herman came out with her bookend book. If you think of trauma and recovery as the beginning of her career, she came out with a follow-up book that is called Truth and Repair. And she introduces a 4th phase to trauma treatment, which is justice, reparations, the recognition of the impact of what has happened, and seeking rehabilitation for offenders. Now, it's important here to distinguish that it's not always about punishment of offenders. In fact, most trauma survivors have enough sensitivity that even though there's a part of them that may be rageful and hateful and carry fury towards their perpetrators, ultimately what they want is reparations and rehabilitation. So as we look at this phasic model to trauma care, We can think of our trauma treatment as occurring in an arc, and that perhaps we move across these phases within the entire arc of our whole treatment process, which can be over many years. But we can also recognize that inside of a single session, we can also move through smaller arcs where we're developing some stability and a sense of safety in the here and now that lets us do a little bit of a deepening in to some of the trauma-related material. And then we have a new gem. We have an understanding of self, and we integrate that into our overall sense of identity, and we bring that into our relationships. And that can happen in these smaller arcs, perhaps even dipping into what justice looks like, what reparations would look like. Even if they cannot get that from the external systems, which may not be doing the work of trauma recovery that the individual is doing, but how could they give that to themselves now, or seek smaller, safer spaces where justice is recognized, where that dignity and respect for what they've been through is honored and attended to? A few of my favorite perspectives on the trauma-informed practice. First of all, trauma-informed practice prioritizes our client's complexity, the social context, and the therapeutic relationship throughout all phases of treatment, including the assessment phase, the diagnostic phase, and the treatment process. And the first requirement is to adopt an approach which will retain our patients or our clients in therapy long enough for the therapist and patient to form a shared understanding of what is happening and to find a way of working together. Here's the truth. When we don't have enough safety and trustworthiness and collaboration in our work with our people, they do not stay in therapy. And that's the biggest cost of therapy that's not well delivered, is that people leave. And then maybe they don't ever go back to therapy because they didn't have a good experience. So we need to work with all of this in mind so that we really create a safe environment so that we can support our people to heal. I refer to this as a foundation of safety, that, we might have a whole list of questions that we might ask someone about their past as we gather information and we try to understand who they are and how they've become who they are and what symptoms they might have. But before we go into gathering all of that information about the past, we need a foundation of safety. And we achieve this by orienting clients to the here and now, and inviting them to pay attention to the cues of safety in the room, and reminding them that there's plenty of time for our work together. I mentioned earlier that I used to work in community mental health, and that can be a tricky setting to achieve this. First of all, when we were trained to do our assessments, we were trained to do this simultaneously typing into a computer, our intake sessions. So someone would come in, we've never met each other, we have a whole list of questions we need to get through in an hour or 90 minutes, and we're typing their answers into the computer. It does not lend itself well to a foundation of safety. We aren't that able to track what might be happening or the impact of these questions on the other person. And it disrupts the social engagement and the attachment relationship between you and the client periodically as you keep turning towards a keyboard and a computer. So being very mindful that sometimes our systems are set up in a manner that isn't as trauma-informed as it needs to be. And so we have to then advocate for things like, I might not get a diagnosis at the end of an intake. In fact, it might take closer to a month or several months because my client feels overwhelmed when I ask a lot of questions about their symptoms. And I don't want to discourage them from staying in treatment. I'll share one brief story here. I had a woman that came to me after reading the Complex PTSD workbook, and she really related to that book. And she came to see me and told me a story about the first time she went to go see a therapist, and it was in a community setting. The therapist, very similar to what I was describing, was asking a whole list of questions, and at some point the therapist asked a question. The client has no memory of what that question was, but she ran from the room and she ended up standing next to her car in the parking lot, and she had no memory of how she got there, and it was terrifying. So we are really wanting to track how is the person tolerating the process at each stage along the way so that we're not overwhelming them? That tolerance of the affect and the sensation we often address through looking at this window of tolerance. This was developed by Dan Siegel, and it's been adapted by others to refer to as the window of capacity. What is our capacity to respond effectively to emotions and sensations? And we think of the window of tolerance as this optimal zone of nervous system arousal. And when we're above that zone, when we're out of the window at the top, we're in hyperarousal, irritability, restlessness, panic, anxiety. And when we're below the window of tolerance, we're in hypoarousal, right? And that we can drop into states of collapse, helplessness, hopelessness, despair, depression. And this also recognizes that those high arousal states, they're not meant to be sustained. We're not meant to be in our sympathetic nervous system for days or weeks or years on end. And that ultimately our nervous system will counterbalance that by taking us down into the parasympathetic. And when we speak about polyvagal theory, we'll illuminate this a whole lot more because we'll see why we can drop into these nervous system states that are characterized by this hypoarousal, parasympathetic, but shut down and collapse. When we're initially in our phase one, borrowing from Judith Herman, our phase one treatment, we are trying to establish safety and stability. And we do this by learning how to be in the window, right? We create these well-paced therapeutic interventions that are helping our clients work through the traumatic memories without becoming overwhelmed or shutting down in the process. So we start with this focus on regulation and staying inside of the window. Once we have some of that safety and stability in place, we can move into our phase two work, where we're working the edge of the window of tolerance, helping clients to successfully handle a wider range of affect and sensations. As we're doing our history taking with our people, I just want to remind us again that there's little clinical value in focusing on a list of questions when this interferes with the relationship. So I invite you to use questions to facilitate conversations in a well-paced manner that helps you learn about your clients' lives. A clinical interview then is also going to be offered at a pace that's not overwhelming the client so they don't end up in the parking lot, right? We don't want to rush the process because that can impair their willingness to continue. Clients may not be able to talk about their distresses as symptoms, right? We might be asking questions and they're going, well, I don't know if I do that, or this is just simply who I am. So we really need to be savvy and listen to what's not being said, watching the body language, tracking that window of tolerance, and sometimes even educating the clients that they can help us pace the process by them noticing how they're doing all along the way. This is especially true when we are working with individuals with dissociative symptoms and when we're developing a case conceptualization. In other words, a case conceptualization is a big picture of who is this person, how do we understand them in the context of their social, cultural, developmental experiences in life, how has this shaped them. That case conceptualization can sometimes be accomplished in a 90-minute intake session, and sometimes it can take months. When we're building our capacity to work with our clients and help to do this safely, there's a skill that I want to make sure that you have in your toolbox. And it's a skill that I initially learned when I was trained in EMDR therapy in 2001, and I've used this ever since. And it's really about the recognition that we need to be at choice about when we're going to think about the hard stuff. And what trauma does is it really interferes with that sense of choice, because trauma is not something that we choose. And it also interrupts that sense of choice that we have about when to think about traumatic experiences. So suddenly we're thinking about the traumatic events in the middle of the night or when we're trying to parent our children and those kinds of experiences. And so to reclaim a sense of choice is the first step in recovery. And it's important to know that you get to be at choice about whether or not this is a good time to think about any distressing memories from the past. And you get to make an agreement with yourself that you will only focus on traumatic memories when you feel supported and resourced. So you can have this conversation with your clients and they'll get it. They'll like, oh, okay, I really do need to build this. I often think of if you're going to go to the gym and strengthen any muscle, we're strengthening the capacity for containment and choice through repeated practice.